Good evening, everyone. Thank you for joining us for tonight's webinar. My name is Zania Day. I'm an interventional radiologist at MGH, and I'll be moderating today's webinar. Tonight, we will be discussing how AI is being used in clinical workflows to accelerate diagnosis and treatment and improve PE patient outcomes. We are very fortunate to have with us tonight an excellent panel of speakers. Dr. Patrick Muck, Chief of Vascular Surgery at Good Samaritan Hospital in Ohio, and Dr. Christopher Hayner, Critical Care Pulmonologist at TriHealth, Ohio. The goals for tonight's webinar are to share perspectives on how AI-led workflow transformations have the potential to elevate patient outcomes by enhancing the delivery of patient care, and to discuss the current AI solutions for PE and how they are paving the way for digital transformation in the vascular space. Before we get started, just a few announcements to our audience. Please feel free to enter any questions that you may have in the Q&A tab at the bottom of your screen, and we will be addressing the questions at the very end in a panel discussion. And also the webinar tonight is being recorded and will be available on the PERT Consortium website afterwards. Our first speaker for tonight will be Dr. Hayner, who will be talking to us about utilizing AI to improve the care of pulmonary embolism. Dr. Hayner.
Thank you, Dr. Day, and first I'd like to thank the PERT Consortium and Viz.ai for allowing us the opportunity to share what we've been doing with PERT and specifically with AI at our institution here in Cincinnati. As kind of a quick background, I'll give you the Cliff Notes version of our PERT journey. Several years ago, a few of us with a special interest in PE wanted to get more serious about improving the process of PE management. And the question that came up at the time is, what in the world's a PERT? And we had rapid response teams and sepsis response teams and code teams, and it seemed that PE was clearly a disorder that crossed several disciplines and required some urgency into the decision-making. As we look back on it, as Dr. Muck can attest, I think PERT version 1.0 was really nothing more than a few interested docs who had each other's mobile numbers. But as time went by, it expanded. We became a little bit more formalized, started actually collecting some quality data and putting more of a legitimate PERT team together. And from an administrative standpoint, it was greenlit fairly easily because there was in no small part due to the fact that it was really a bunch of willing providers and it didn't have any cost associated with it. But after a few years, we recognized that it wasn't really efficient. It was somewhat insulated, a little bit clunky, and certainly wasn't a real reproducible process. And at that time, we began to explore AI options. And then that generated a whole nother set of questions, specifically with administration, such as whether we were going to get a return on our investment and how it was actually going to funnel into improved quality and efficiency and outcomes. But at least for the past almost 2 years now, we've been up and running on the Viz PE platform, and I think it's checked all of the boxes for all of the interested parties. And what I'm going to start with is just the next half dozen slides to kind of walk you through some of the clinical decision makings that go into a PERT team, and then how we use AI to improve both decision making as well as efficiency. And the first slide, I guess, is the obligatory stratification diagram. It's probably familiar to most of you. You've seen it nearly every PE talk you've heard in the last 5 to 10 years. But I think it's still useful, specifically to focus in on the waters where most PERT teams tend to swim. And so these are the European Society of Cardiology subset definitions. On the different sides of the screen, on the left side, we've added prevalence, and then on the right side, the estimated mortality. And then I've also added some of the generally accepted treatments that go into the different subsets. So very briefly, the green box is the low-risk PEs. That's signified by a negative S-PESI score. It comprises about 40% of cases and has a fairly low mortality. The real acute decision-making here is mostly limited to whether the patient needs to be admitted at all, or whether this is something that can be managed as an outpatient at discharge using things like Hestia criteria and the like. The next box, the yellow box, is about 40 to 45% of patients. These patients will have a positive S-PESI of at least 1. They may have elevated biomarkers or RV dilatation, but they clearly don't have both. By definition, the mortality does creep up in this group somewhere within the 3 to 5% range typically. But again, at least acutely, probably the majority of these patients will be admitted, but still managed with routine full-dose anticoagulation. And there's not much more that we do specifically toward those patients on an acute basis. So that's about 85% of the PE patients. And if those were the only two cohorts that existed, you could legitimately make an argument there's no real need for a PERT team. But in fact, our PERT team, and maybe even most, don't typically focus on these groups, since the management is fairly straightforward and mostly guideline driven. And all of our concentration and energy tends to focus on that top 15%. And certainly if you start from the top and then go down, the top box of 5% of patients with the 30% mortality is the high-risk patients, defined by hypotension, hemodynamic instability, or shock. Here, speed is of the essence, and to a large part, the immediate management tends to be driven as much by institutional resources as anything else. So questions like, is TPA your quickest, or maybe at certain facilities your only option? Do you have ECMO capabilities? How quickly can the vascular lab be activated? Even things like staffing and time of day probably play into whether these are options or not. And then there's also the expansive list of absolute and relative contraindications to several of these forms of therapy. At our institution, we have 2 spokes and we have 2 hubs. At the spoke hospitals, due to resource availability, we're inclined to use systemic thrombolytics more commonly, whereas at the hubs, where we have other options like catheter-directed lytics, systemic thrombectomies, or mechanical thrombectomies, ECMO, and surgical options, the options do tend to expand and the discussion gets a little bit more robust. The real hot spot, though, for most PERT teams, and ours specifically, is in this gray box here. And it's gray for a reason, obviously. And this is the intermediate high-risk patient population. These are cases where technically you have more time than in the red box. But you really have to try to decide whether the patients in this category lean toward the red or lean toward the yellow, because the treatment options are very different. And then also, how do you know which direction they lean toward? Because we really have the least clinical consensus on how to manage these patients. We have some direction with respect to systemic lytics from the PYTHO study, where the PE mortality was cut in half, but we doubled the risk of major hemorrhage, including significant intracerebral hemorrhages. And so at the end of the day, there was pretty much an equal all-cause mortality between groups. And then on the catheter front, there are multiple options. And certainly to date, we've mostly been hamstrung by the lack of robust RCTs to look at clinically meaningful endpoints. I mean, some of the studies can show on-table symptom improvement. Almost all of them show very similar RV to LV reductions at 48 hours, but how that translates into the bigger picture is still somewhat uncertain. And then clinically significant differences like functional status, quality of life, downstream CTEPH, and those types of things are being measured now, and their results are starting to trickle in. But as of today, I think it's fair to say we have more options than answers. If you look at this slide, it's sort of a version of the last one. Essentially, what I've done is just tip the pyramid on its side. And what I'd like for you to do is mostly focus on the right-hand side of the screen, specifically the pink and red box where the intermediate high-risk PE patients are. And I've superimposed on those the ESC criteria for treatment. And whether you use that society or any one of several others, they all tend to be iterations of the same thing. And so strictly from a guideline standpoint, treatment tends to be relatively binary. And that is that it would recommend that every hemodynamically stable patient be treated with full dose anticoagulation, and that deviations would occur only if and when the patient deteriorated. And I think that doesn't sit well with a lot of us, and particularly it presupposes that the intermediate high-risk population is a very homogeneous box, and clearly it is not. Also, things like conventional scoring with biomarkers and RV-LV ratio don't really stratify them into a different level of severity. And we know even from like flash registry data that at least a quarter of patients in this group will have cardiac indices of less than 2.1. So there's a sizable percentage of occult cardiogenic shock even within that hemodynamically stable box. And patients also aren't going to really telegraph when they move out of that 5% mortality into the 30% mortality and give you enough time to make some clinical decisions. And so we'll talk about ways to sort of enhance risk stratification in a little bit. But suffice it to say, at this point, this rigid cutoff tends to make a lot of us nervous. And this slide helps me realize that I'm not crazy for being nervous. And it's probably certainly the oldest slide that I have and probably the scariest. And this is data that's 70 years old from Guyton. If you look at the x-axis, it shows progressive occlusion of the pulmonary artery. And then the y-axis is pressure. And the 4 lines at the bottom part of the screen are pressures that are measured either in the proximal or distal pulmonary artery, and then the right-sided chambers. And you can see that sequentially, as these pressures increase, there's still fairly good compensation going on, because the only pressure that we're actually measuring in real time is up here at the top, and that's systemic blood pressure. And so it can be maintained for quite a while there's a lot of problems still going on under the hood, so to speak. And so at this point, a point gets reached where you have a precipitous decline, and that's when mortality increases about tenfold. And so from my perspective, this is really the only slide that you need to see to justify having a PERT team. And the goal of the PERT team, one of the principal goals, is to keep this from happening and to try to intervene at a point before it becomes much more catastrophic and into rescue therapy. So then, in general, why have a PE response team at all? Probably the biggest reason is to try to better enhance risk stratification of that intermediate high subset. And part of that is that, as we mentioned, there's a real heterogeneity in those patients. You can see from the Jenga blocks on the side that the 3 blocks at the bottom are sort of the standard criteria that we use. But then you can build on that, and there's evidence in the literature to support each of these things. Serum lactate certainly can correlate with increased mortality. Additional CT scans findings beyond LV-RV ratio, such as where the septum is, how much does it bow into the left ventricle, the size of the pulmonary artery, the contrast reflux into the vena cava or the hepatic circulation. We will occasionally ambulate patients. If you have a patient that looks pretty good while they're laying on the stretcher, and then you get them up and just walk them across the room and they get lightheaded and tachycardic, that's a fairly decent sign that there's probably some problem with fixed cardiac output and the need to take that one a lot more seriously. And then we also have built into our EMR the ability to monitor the NEWS score, the National Early Warning System score, over the next 16 to 24 hours, specifically to make sure that the trajectory doesn't change from what you assumed it to be when you first saw the patient. You already mentioned that the options for treatment have gotten ahead of the evidence to support them. There's a number of good studies that are going on right now specifically addressing these, and hopefully within the next year or so, we'll be able to take this bullet out of the slides. Decision-making tends to be fairly slow if it's done in series as opposed to parallel. And then often in these cases, we'll have 4 to 5 different services involved. And it's really hard if you're skipping from one to the other, to the other, to the other in a sequential approach because time is sometimes of the essence, and that's a very inefficient process. And it's also more important if we can leverage multiple real-time opinions to strengthen whatever recommendation we're going to come away with. So these 5 slides show how we used AI to sort of fill in some of those gaps and concerns that we have. And you can see, I'll just kind of walk you through these one by one. The first slide is the initial notification that a PE has been detected that's more proximal than just subsegmental. And it's a fairly innocuous alert. And so the members of the team that are signed in will get this alert, and then on their device, they can look through the various images that can be shown coronally, sagittally, and axially to get an idea of clot burden, clot location, and some of the other signs that we mentioned. And then the middle box is where clinical information lives. Some of this gets imported. Some of it you can manually enter based on local knowledge and specific knowledge of the patient. For example, if they have a contraindication to lytics, those kinds of things can be added into that column. And then the fourth column box is where sort of the real meat of most of what we do lies, and that's the chat room. And this is where everybody that's activated can get on and can provide questions, opinions, and we can have a discussion in real time going on to determine what the best strategy is. And then the last slide has a number of functions on it. The two to draw your attention to are how you activate the system. So I mentioned that the first alert's fairly innocuous. If you've gotten that alert, you've looked through the slides and said this requires more attention and more input, you can hit a PERT button, and that's a much more annoying notification system that's kind of like the APB that gets put out to really request that other members join in to provide some additional input. Beyond that, there's even yet another button, which is kind of, we call it the nuclear option. That's when we want to bring in ECMO, cardiac surgery services, that kind of thing. It's helpful to have this because that way you're shielded from a really poor signal to noise ratio. So in other words, if this is never going to come to the attention of cardiac surgery or ECMO, they tend to not get the alert to that extent. And so we can sort of tier that to improve user satisfaction on the physician side of things. So here's kind of how this works in general. All of the data is housed on the mobile phone. You can also get it on a desktop. The alert comes from the X-ray department or the X-ray machine in probably 60 seconds or so. If it takes you another minute or two to scroll through and see what's going on and whether you think this rises to a higher severity, then you can hit the PERT button. And so we can often start discussions before the ED doc is even notified that the patient has had a pulmonary embolus and they're not even back to the ER yet, and go ahead and get the discussion and treatment plan activated. And then the last slide I'll show is sort of a representative case of how things have worked on our end. The PERT notification goes out from the cloud that's hooked up to the PAC system. You get the initial ping, and if you can look on these timeframes, you can see that the initial scan was at 7:24 p.m. So I put that in specifically because people aren't in the office at that point. Nobody's in the OR. Hopefully everybody's at home, but this is kind of semi-downtime. And even just going through the scan, looking at the location, looking at the RV-LV ratio, looking at the clinical information, we initiated a discussion. And on this particular discussion that you can see on the far right side, there was a hospitalist, a pulmonologist, an intensivist, a vascular fellow, and a vascular attending that had all logged in and provided input. And we had established a transfer from the spoke to the hub and a treatment plan within about 35 minutes. And that's something that clearly would not have happened in the pre-AI days, where probably within the first 35 minutes, we were still either looking up phone numbers or waiting on a callback. So I think from that standpoint, it's made the efficiency much greater. And with the efficiency comes the increased multidisciplinary input, as well as ultimately improved care for the patient with PE. So thank you for allowing me to be here, and look forward to the conversations at the end.
Thank you, Dr. Hayner, and thank you for sharing with us the workflow and how this platform works. Before we transition to Dr. Muck, I just wanted to ask a quick question. Since you showed the EHR integration, what have you found the value of having all the relevant information integrated and easily accessible in one place, including the lab results?
So presently, it's still a work in progress. What we have currently is we can input lactic acid, we can input the biomarkers. What it's allowed us to do is to get a better and more broad overview of what's going on, as opposed to still having to break out of the app and go into either a different app on our phone or to log onto the computer to the EMR in order to get specific information. Ultimately, that still occurs because there's a lot of nuances involved in patient care. But for the most part, it has been able to allow us to do more one-stop shopping, specifically just through the app. And as that gets built out, I think that will be even more powerful when you can look at medications, comorbidities, past medical history, some of those kinds of things, vital signs and whatnot.
Thank you, Dr. Hayner. And I think it's very important for our audience to know a little bit about the integration and how that helps at the point of care for clinical decision making. Next, we'll be moving to Dr. Muck. Dr. Muck will be talking to us about the clinical impact of AI-based care coordination. Dr. Muck.
Hey, Danya, thanks so much. And thanks to the PERT Consortium, and thanks to VizAI, and thanks to Chris. I'm a vascular surgeon. I started at Good Samaritan in 1995, so a few years ago. That's when I met Chris. So I've known him ever since then. And back in 2012 is where we all got together and followed, your all's lead at MGH and Kenny's lead with developing a PERT team. And as Chris said, it's worked well because we're probably a medium-sized hospital system, and we know each other and kind of like a family. But obviously, not all institutions have that, small and large. But with that, as Chris stated, we've had some room for improvement, and that's where this technology has really taken us to the next level. Literally, if I'm looking at my phone, and if I get an alert in no time, as you can see, I can pull up this little, there it is. You can kind of see in no time how quickly you can go through your CAT scan, and I can communicate with everyone on the team, and they'll let them know if we think this is or if it is a saddle, or if it's a lobar, or a more distal, PE burden, and really communicate rapidly and quickly. And I'm going to show you all that. And then subsequently, our training program, we're fortunate. It's the second oldest vascular surgery fellowship in the country. And with that, we, in working with Chris, we took some projects to our regional meetings here, and I'm going to share with you some data that I think is pretty exciting. So as far as VizAI itself, I got to know them over, a year and a half ago. I got to be at one of their meetings in Denver and speak, and I got to say that it's pretty encouraging to see a company that makes a point to hire reps and team members who are experienced in the field, whether it be in the cath lab or in the specials department. They're not hiring folks that had experience doing dental implants and things like that. Not all those things are important, but when it comes to this field, their reps and their team members, they definitely understand this space. That's what it's been, so exciting for us to work with them. And I'm certain the other companies out there follow the same lead. I can just speak for my experiences with Viz. So as Chris already kind of eloquently went through, AI is really enabled communication, rapid risk stratification, and it all starts with a diagnosis that's literally right on your phone. And I'm excited to tell you that we're getting ready to submit to the American Venous Forum, where we adjudicated what was kind of already known, but we wanted to do it at our home base. And we looked at a series of radiologists as well as one radiologist, and compared all of the RV/LV measurements with Viz. And so kind of a non-industry sponsored research project, and we're getting ready to submit this abstract. But it showed that the AI software was right on the money, whether it be the whole conglomeration of radiologists who read several patient scans, or the one that we had go back and retrospectively look at 40 of them. So, the point of all that is that this technology is on the money, it works, and it's accurate. So as Chris said, you can really kind of customize your vascular report. At our institution, admittedly, I feel like I know a heck of a lot about PE over the last 12 years, but we rely on Shayla Malik, Chris's partner, and we rely on Chris. We're kind of the service that's there. If folks who've been dealing with patients afflicted with pulmonary emboli for 30 plus years are going to know more than the vascular surgeons and our trainees. So we really rely on Chris, and we're kind of the hands when it comes to interventions that are needed. And but with that, at home, you can customize your vascular report. I set it when I'm on call to be notified for PERT appropriate as you should. And then again, it'll click off. It'll give you the RV/LV ratio and then all the appropriate demographics as well. So what we did a year ago was we took our initial experiences with AI, and looked at this technology in the detection and treatment of PE at our tertiary referral center. Shout out to our 0 and 5 integrated 5th-year resident, Jake Shapiro, who's going to head to Florida at the end of his residence here in June. He did a tremendous job, but obviously we all kind of chipped in. This is all the vascular surgery department, and then Chris representing the pulmonary department. And what we looked at was the detection and triage with the PERT team pre and post AI. So our AI-based software was implemented in October of 2022. Again, Chris was at the lead and all that. And so what we did was we looked at our patients from before then and then after then. We had to stop in March because that was the deadline for this meeting, the Midwest Vascular Surgical Society. And that's why these numbers are relatively low at the time. But we wanted to look pre-AI and post-AI, was there in fact a difference? And so here, again, it's a low number, but I told you why, and I'll show you some higher numbers here shortly. But the bottom line was we looked at the time to consultation without AI. We looked at the time to the radiology report without AI. And then we went back and looked at it with AI, with PERT activation and without PERT activation. As Chris said, he is the kind of the nuclear buttons to press there when need be. And so we went back and looked. And it's kind of a busy slide here, but what you'll see is on the left there, it took a heck of a lot longer, albeit, there's some outliers here. But usually when we get our consults, it's within about 2 hours, give or take, of when the PE was diagnosed without AI. With AI, again, you're walking around with your phone. I was lucky enough to be at a meeting in London in April, and I left my PERT activation on accidentally. I'm over in London and getting notified, and you think about it, and a patient's not even back from the CAT scanner, as Chris alluded to, and the ER doc hasn't had a chance to go back and find the reading and risk stratify them, and I'm over there, and I already know what's going on. So essentially, I got consulted all the way across the Atlantic. In one of my 5 partners, I think it was Adam, was on call at that time, took care of it. But again, it's crazy technology, and with that, when the PERT is activated, I think everyone's kind of committed to providing the appropriate care. And you see here that we, in fact, had a quicker time to the final radiology read with PERT activation in the post-AI group. And here you can see it was in the post-AI, but without PERT activation. So it really shows you that this effectively and quickly will diagnose the problem. It'll lead to the consult. It can lead to a quicker radiology reading time when you have activation of the PERT. So these are our conclusions at that time. Again, low numbers. It was because our abstract deadline was coming up, but we wanted to look at what we had. So what we did now is we looked at a longer time period. Now we had a much broader, kind of robust patient sampling. We looked at pre-AI from all the way back to January of 2017. Then we looked at October all the way to July. Again, the deadline for the American Venous Forum is in August. So we had to stop with this number of patients. But what you see again is what we showed you in our department, and the pulmonology department kind of showed you before with that prior study. Now with a little bit more numbers, you can see here again, pre-AI and post-AI. And again, the time to alert, the time to consultation is much quicker. We also looked at time to anticoagulation. And what you'll see here is that it's quicker time to anticoagulation when you have PERT activation as opposed to without. Shout out to Rachel, your president on for PERT. The reason we got this idea was doing a webinar with her and realizing that your mortality every hour that you're not anticoagulated with a pulmonary embolism increases your mortality. So that's how we came up with the idea. So thank you, Rachel. And as you can see here at the bottom left and bottom right, you see a significant decrease in the in-hospital mortality pre and post AI. Now, of course, we've got much more work to do, many more patients to look at. It'd be nice to be look at something multi-center, multi-institutional, but at least at home base with us, this is what we found. And so then again, here's our conclusion. And the use of AI for the identification and triage resulted in a faster time to assessment. And it also decreased your mortality likely by quicker anticoagulation. So subsequently, I was then invited by the folks at the DeBakey Cardiovascular Journal. You know, in my world, Houston and DeBakey is where it all started in the cardiovascular surgical field. So it was a real honor. We got to go back and review the data, then participate in a webinar with them a few months ago, kind of highlighting the benefits that Viz.ai brings to this patient population. And then finally, I want to close with what Chris alluded to, as you'll see here on the left. Here we are. So this was just on Sunday. Chris and I were on call, and this, I think, highlights how you can get rapid communication, rapid identification of the problem, rapid communication amongst all the specialists. And if you just look at this, the timestamps here, it's pretty impressive how quickly. This is my vascular fellow. We're talking about a patient, a neurosurgical patient, who had a contraindication of lytics, had a catastrophic PE, coded. Here's our neurointensivist, Chris came in, had after the ROSC, got the patient back. And again, we're all kind of coordinating care on if they're able to get anticoagulated, what's the best therapy. Here's my kind of thoughts at that time. And it really just brings home that, all this can be on your phone. You don't have to get on your Mac, go through your password to get on your Mac, get on the internet, get on your hospital system. Usually every 3 months, I got to change my password. I forget it. Then you get locked down every now and then. And it can take 15, 20 minutes sometimes just to get on Epic with our system and look at the CTA and offer your opinion. Here I was able in no time to offer my opinion after I was able to look at the CT scan and the RV, LV, et cetera. So it doesn't matter if you're at home. It doesn't matter if you're over in London, your kid's lacrosse or soccer game. You just pull it up right on your phone, and it's crystal clear imaging too. That's what I think is not really talked about enough from our AI colleagues. So to that end, thanks so much. I'd be happy to take any questions, and I look forward to the conversation. So again, thanks to PERT, thanks to Danya for and Viz.ai for having us.
Dr. Mark, thank you so much for sharing your experience, and especially for sharing the data showing how this can influence patient outcomes. Before we jump into the panel discussion, I just want to remind the audience to please type any questions you may have in the Q&A button that you have at the bottom of your screen. And I'll just start with a few questions for both Dr. Muck and Dr. Hayner. Just going a little bit deeper into the algorithm itself, what has been your experience with the algorithm specifically in terms of false positive rates, which I know many of our audience will probably have questions about?
They exist. I don't know what the percentage is. I think it's low single digits. But I will say that from a practical standpoint, because we're more focused on what to do with proximal PEs, if there's something that's a isolated low bar or beyond, it probably doesn't change our management stratification to any great extent. So I think bifurcations, I think the presence of pre-existent lung disease, structural lung disease, sometimes it could be thrown off by bulky adenopathy. So I think if you look at the CT scan and you still have to read it as a CT scan and not just as an angiogram. And I think if you do that, then sometimes you can kind of work around when the alert goes off, but there's really nothing much to see there.
Yeah, I would echo that, Danya. I think that there's a couple times I can think of, like Chris said, single digits, that perhaps the RV/LV may have been a little overestimated by the app. But I think what Chris was his point too, as I would agree, is that you'd rather that than undercall it. But to that end, like I told you, we're getting ready to submit, and our 40 retrospective CTAs comparing AI versus the official radiologist who read it. And then we employed Mike Wolujewicz, our single radiologists, all three of them correlated. So it's on the money, and it doesn't miss that often, I would say.
And that's very, very helpful to know. I mean, I'm looking at the chat here, and there are a couple of questions along the same line. So maybe I'll follow with a related question. Does PERT ever get activated or through the app when PE incidentally is found on chest CT that's taken for evaluating people for pneumonia or things other than PE? And specifically, they're asking, do you have an alert for regular chest CT scans, not necessarily CT angios?
We have incidentally come across PEs when we've been looking at aorta. So somebody who comes in with chest pain and the prevailing diagnosis is, could this be a triple aorta dissection? And we didn't specifically run the PE algorithm through the PACS as a coded diagnosis. I'm not sure where we stand on correcting that, but I do know that of at least one or two cases where we've stumbled upon a significant PE through a different algorithm.
And just going back to the care coordination piece, I know we talked a little bit about having clinical information integrated into the app. And there is a question in the chat here about adding point of care echo data for early evaluation. Is that something that's currently incorporated into this?
That would that's not been incorporated as a direct pull-in from Viz. The point of care echo, whoever the technician is, generally one of the intensivists or the ED doc, if it's after hours, or the echocardiographer during the daytime. That information, some of the information would typically still get entered manually, but you could still have it in the app. You know, so you could still comment on it, but it wouldn't necessarily have a real robust reporting. But I don't see any reason why at some point, I know this is all kind of next generation stuff. And it's when we started with Viz AI, we didn't have the ability to put in labs straight from Epic. Now we have that. And so, you know, that we've kind of broken through that. There was a lot of technical barriers that I'm not really able to talk about with any great intelligence, but things like firewalls and the ability for one language to speak to another, a lot went on behind the scenes just in terms of pipes and plumbing to try to get that established. But I think now that that connection's been made, it should be much easier to continue to add, you know, points of interest directly into the app through Epic.
That's very helpful to know. I think this integration with Epic is something that many people will be looking for when making the PERT decision and whether or not to activate. And going specifically to the communication piece and the care coordination, there is also a question about the communication through this app with the primary team taking care of the patient. The question is asking specifically about situations where the primary team is assuming the PERT is involved because of the app, but they are not, or when the primary team does not want the PERT team involved, but there's an alert that's generated as part of the app. And have you had any situations where that took place, and how does the care coordination work in those situations?
So if the patient's still in the emergency room, oftentimes that'll just be communicated back to the ED doc, who will then talk to the hospitalist. We have a separate messaging system, you know, on our phone to separately message the hospitalist. PERT team reviewed this. Our feelings are such and such. And then also for cases that are maybe a little bit more complicated, we have templated notes that you could put in to have a written record of what the PERT team discussed as well.
Great, and that's very helpful to know. I think the care coordination piece is very important for everyone who's using this app, and making sure, obviously, that the PERT activation isn't within the goals of care for our patients. And now just changing directions here a little bit, I want to talk a little bit more about adoption of this new algorithm, and how do you go about really convincing your colleagues to start using this app? I know not a lot of people like change. And did you encounter any pushback when you adopted this app clinically? And how was the adoption?
The easiest way for us to do it was to package it in terms of a bigger PE strategy. And part of that is because just how murky expenses and costs and charges are with respect to a hospital system. I have no clue how much a catheter costs. I don't know if we're getting them on discount by bulk or exactly what. So I couldn't tell you that, and I can't tell you the reimbursement. But as part of a bigger package, things that I do understand is sort of longitudinal care and how that plays into it. So the easiest way for us to get this through administration was to talk on the backside of things, because especially when you're dealing with a disease that doesn't have a super high mortality. I mean, it's got a high mortality, but when you're talking, 3 and 5%, it takes, a considerable volume before you can make a definitive difference there. And then, other things, if we can capture those patients and put them into an outpatient PE follow-up program so that we know that they're going to have at least one visit with a hematologist. They're going to have at least 1 or 2 visits with pulmonary or with critical care, cardiology, or they're going to get a 6-month echo to screen them for CTEPH or CTED. Those are measurable costs. And I think part of this was packaging it in a bigger program so that you didn't really focus so much. I mean, now that we're using DOACs instead of Coumadin, I mean, you've shaved as much time as you can possibly shave off an inpatient stay. These aren't 7 and 10-day stays, like they might have been 15 years ago. And so really you have to kind of figure out where you're going to make this up on the back end. And that's where we focused. And that was ultimately what got sort of the seal of approval from administration, was showing the ROI in terms of a broader package of managing PE patients in general.
Yeah, not really the purpose of this, Danya, but on the aortic side, we followed Chris's lead, and that's how we pretty much got it approved. Our office can go the next day. It keeps a log of all the patients, and then thereby you can increase your follow-up for that patient population with, CAT scans, ultrasounds, et cetera. So that's how you can show your ROI to your administrators. So just like Chris did. So it's not just here in the PE space. We all know, obviously, in the neurosurgical space from stroke teams, it works so well also.
Yeah, absolutely. I mean, I think really this ROI question comes up a lot when we're talking about the new AI algorithms, and how do we get our institutions to adopt them with the cost associated. I think this is definitely still the elephant in the room, but certainly with some of the data that you presented today, especially with the mortality piece, I think this is definitely going to make a huge difference in showing the ROI. I'll make one last call for our audience. If there are any additional questions, please type them in the Q&A. And while I'm waiting for that, I'll just ask one more question here. Really, for anyone here in our audience who's looking to approach their institution to really make the case that they would like to get an algorithm, how would you suggest that they approach this conversation from an ROI or other angles to have a successful outcome?
PERT Consortium does have a partnering program where you can be put in contact with someone who's been there, done that. I know I did that with Dr. Charles Grosden, and it was very helpful for just discussing some of the pitfalls and traps that I didn't know that would exist. And so it wasn't so much a clinical talk as it was kind of covering processes and approval mechanisms and that kind of thing. And so I think that's probably the best step, is to reach out to the PERT Consortium, and they're more than willing to help put you in contact with somebody who can walk you through it, and is available, fairly easily, and are more than willing to invest their time in your program.
And Donnie, going back to the one question you asked about people and change, no one likes change, right? Um, we were probably part of that crew until we saw the platform, and then the light bulb kind of goes off that again, no matter where you're at, you can pull up in no time, and we all know you're interventionalists. There's saddle PEs that are thick, and then there's saddle PEs that are thin, and oftentimes we're sold a bill of goods by folks at outlying institutions on we need to accept this patient and rush them in for an intervention, when it's all right there with pretty crystal clear imaging on your phone. Once people see that and experience it, then you're sold. Then you're like, holy moly, I can't believe I used to carry my Mac to all those football games and soccer games and try to log on when somebody called, when you could not even get out of the stands and just look at it right on your phone. It's so easy. So I think that once they see it and experience, and I'm unaware of this program Chris has talked about through the PERT Consortium, that's a great resource. Once you see it, then you believe it. And some of our radiology colleagues in the beginning, they didn't really buy in. This isn't replacing any of that, obviously. This is just leading to quicker diagnosis and risk stratification and communication amongst all the players. It's not going to replace anything, that's for certain.
No, absolutely. I mean, I think this will definitely transform how we practice. I mean, based on the data and the experience that you both shared. I'm not seeing any questions here in the Q&A. So before we end, I'm just going to ask both of you if you have any final comments or recommendations for anyone here in the audience before we close.
From my standpoint, I'm drinking the Kool-Aid. I'm a firm believer in PE response teams. When you look at data that show that pulmonary embolus has a mortality greater than motor vehicle accidents, HIV, and breast cancer combined, I think that puts it into perspective that this is a field that is ripe for a PERT team. And this is the golden age. This is the when I was a fellow, we had heparin, Coumadin, and if you were daring, TPA. But for the most part, we lived in a world where heparin and Coumadin were your only drugs of choice for probably 50 years. And now there's just an explosion of different options that are specifically, and Pat knows this far better than I do, catheter-based options. I can't even keep track of the numbers that are out there and the studies that are going on. But this is the golden age. And this is a great time to be involved in PE care because we've been able to really make changes, and I think the data hopefully will catch up with the technology, and we'll be able to support that in far greater details going forward.
Yeah, from my perspective, it's kind of exciting that Chris and I have taken the research side of it as well. We know Rachel taught us that every hour that you're not anticoagulated, your mortality goes up. And now we have peer-reviewed publication in the Methodist DeBakey the Cardiovascular Journal showing that in fact AI decreased mortality. So it's kind of exciting to play a part in the development of the research and really being a proponent of this technology. And again, we owe it to Chris. He had the foresight in October of 2022 and brought it to us. And it'll be exciting to see other kind of institutions bring this technology on.
Thank you again, Dr. Muck and Dr. Hayner, for sharing your experience tonight and for really showing us how AI can really transform the care for PE patients. And for our audience, thank you for joining us tonight. Have a good night.